Friends, ladies and gentlemen, welcome to ERCP master class. This is second of our master class, and as I said, this particular ERCP master class is for the surgeon by the surgeon, and we are going to have 5 modules during which we will give you and share with you all the tips you need for doing an ERCP. And once we finish this online module, I hope we will meet sometime after the COVID pandemic and teach you and all the tricks we learned in the last class and this class and the subsequent classes. Okay, let's go on today. That is trying to tell all the final tips today regarding how to prepare a patient, what are the equipments we need, and how to educate your team, and what exactly you should do during the procedure. So I have classified them into these 4 broad categories. As you can see, the patient preparation to start with. We need to know, for example, whether the patient is coming in for ERCP for a right indication, because you should say this procedure you can't take it lightly. So there should be a definite benefit, a therapeutic intention for you to do the ERCP. ERCP is no longer a diagnostic modality. If you need somebody to have a biliopancreatic problem, needs to be addressed by diagnosis, we have MRCP, US, CT contrast. So better we confine ourselves to have a definite indication like a CBD stone with a jaundice, or gallstone pancreatitis with persisting stone in the bile duct, or increasing jaundice or sepsis. These are the 2 common indications I normally do. But in addition, I am sure in some situations, especially when you have a patient with a malignancy, biliopancreatic malignancy, they need a palliative drainage. Yes, it has a value, putting either a SEM stent or a plastic stent, or occasionally we do, especially when there is a very high level of bilirubin in a patient with operable cancer, we will be able to do a preoperative drainage. So these are all the possibilities we could think of. But I should also tell you about this so-called soft indication. Especially when you are a beginner, try not to do surgeries when the indication is not very strong, like trying to make a diagnosis of sphincter body dysfunction, and don't do it especially when the patient is having a coagulopathy. So these are the things I would think that has to be done. And as I said in the last class, probably you may refer to the last class to see how I explained about the importance of the informed consent, because informed consent is a very important document that has to be signed after giving the patient the following details, namely why we do the procedure, the indication, and how we do the procedure step by step, starting from the anesthesia, what the patient is going to experience in OT, and what happens after the procedure. If it succeeds, what happens? If it fails, what's the alternative? All those things you need to tell. And of course, there are risks involved with ERCP. We discussed last class, like pancreatitis because of ERCP. So you have to tell them all, like what I have the mnemonic here, WHO, what, why, how, and the outcome. So once you have the content of disclosure very clear, and also with the patient in front of you, with the relatives asking ample questions, and also give him a pamphlet in their own language to see, understand, then consent, that if it is given voluntarily, that is a legal document for you, then we can proceed. But of course, some pharmacotherapy here, especially when a patient coming for ERCP, preoperatively, all the patients I need to check apart from the LFT, 2 important things. The INR, especially when a patient with a jaundice, if the INR is more than 1.4 or 1.5, I like to give them at least 3 doses of vitamin K, 10 milligram IV. And consider during and also after the procedure prophylactic antibiotics. The 3rd generation cephalosporin, especially IV cefatoxime, is a drug of choice for me. The second thing is coming to the anesthesia part. Even though I am sure large number of people they do under deep sedation the ERCP, in my opinion, I think the first few cases, especially when you have a mentor and you are having your time, better you do it under GA with anesthetist presence. That takes a lot of stress on you. So short general anesthesia, especially with a tube in place, gives you a lot of comfort for you to go ahead and do the cannulation. The cannulation rate definitely is going to be better in your beginning. Next important injection, of course, is the contrast. The same contrast what we use for the CT. Here it is, even though it is can be excreted by the kidney, better you ensure the patient creatinine is not too high. And usually my recommendation is to go for 1:1 dilution of the contrast, so that minimize the amount of contrast. And also my dictum is never fill the obstructed system unless you are able to go above it with a guide wire and into the catheter, because no point in pushing under pressure the obstructed system. Then if it gets infected, if it is not drained properly and definitely early, then there is a chance of cholangitis and sepsis. So be careful about injecting too much of contrast or too much of pressure, especially in an obstructed system. Buscopan, yes, we do use Buscopan. Some people do without giving the patient Buscopan. 20 milligram Buscopan at the right time. Keep the duodenum immobile, and ampullary cannulation is better. The last one we normally recommend, especially when you have multiple prodding at the ampulla. There is a theoretically you have increased risk of putting the patient into risk of post ERCP pancreatitis. I think this has been proved again and again by giving them a rectal diclofenac or indomethacin just immediately after the procedure, minimizes the intensity or the chance of post ERCP pancreatitis. So these are the few things I thought is worth sharing with you, and I think we have discussed regarding the equipment to some extent last class. Let me just recollect, because this summation of the 5 module is going to make you so knowledgeable and your cognitive skill is so good, you will be itching to go for your technical aspects or technical training. And this is what we call the scope and how it look like inside. As you can see, this side viewing scope, as you can see here in this picture nicely. See, you can see the side viewing camera along with the light and the insufflator. But what is most important is this particular elevator, because the elevator, the control of which you will soon find out in the video I am going to show you, is going to be just close to the big wheel. So you have your camera taken, your endoscopy, the duodenoscopy in your left hand, not dominant hand, and the big wheel, whatever is next to the big wheel, you have the up and down the elevator. So that you need to control, so that you are able to get into and able to see what we call the medial wall of the second part of duodenum is nicely seen thanks to the side viewing scope. And this is a close-up view of a Fujinon scope. As you can see, the tip can be disposable because the chance of Pseudomonas infection is so high. So you should have a rigid disinfection protocol in order to clean these intricate parts with the appropriate brushes and a good disinfectant, proper dwelling time. All those things had to be religiously kept. And this is a little picture to show you how an elevator is going to help you, as you can see here. And as soon as I put my hand in the insert, you can see, and bring the thing down like this, then it takes it up like this. So you finger down on the elevator in the control head, and the elevator lifts this thing and it drives these accessories into pancreatic duct or biliary tract, depending upon the amount of the down you are making and also the angle at which you are going. So elevator is so essential. I think that is going to make a difference. So if the elevator is not functioning or it breaks in the middle, you may have to abandon the procedure unless you have a spare equipment. So that is as simple as that. And this is a mechanism. Elevator, if it is something happens, the mistakes or some damage, it is a very expensive thing. As you can see from here, where from the elevator, here you can see where it is attached, how the wire is coming all the way here, and right at the end here you can see, and that how it helps. So this intricacies inside the design you need to understand, then you know how difficult to repair. They have to really dismantle the whole endoscopy or duodenoscopy in order to rectify the problem. And I told you already in the last class the importance, as you can see here, and the proper elevation, proper angulation will bring you selective cannulation, either the PD or a CBD. And this is the room layout. Just roughly to say that patient, imagine the patient ideally in a supine or a prone or a left lateral, whichever, in a radiolucent table, and where the assistant nurse too, it says here, is actually my anesthetist normally stays there, because I do it mostly under GA. And endoscopy is myself, my staff nurse on the right is my right hand, she will have her trolley. And you can see nicely placed ergonomically. Both endoscopy monitor and X-ray monitor is next to each other, so that I can have look both this and interpret. At the same time, you should see where it is coming from. The other end here, C arm is on this side, it will come this side. So, it will not interfere, and the diathermy will be somewhere here, the machine will be kept. So, all those machines, so you need a spacious minimum 16 feet into 16 feet theatre is what you require in order to have a very good comfortable working atmosphere. And I also told you last class regarding the importance of the image intensifier, how it works, and the gear you need to put in order to protect yourself. Lead apron, thyroid cover, goggles, all are important not only for you but all your staff should wear them. And these three equipments, out of which the energy source, especially the one which can do what we call endocut, is very important. Of course, carbon dioxide insufflator is optional, but it is essential when you are going to use spyglass, and irrigation definitely it is of immense help, especially when you have a problem with the bleeding and other issues. Okay. Now, always you teach your staffs to keep them all nicely on a big trolley, so that you know exactly what you need. Like here it is kept nicely, as you can see. I need a sphincterotomy. Most of the time the cannula is no longer used. Especially we start with the sphincterotomy, wire guided sphincterotomy, hydrophilic tip. This is what we use. What type of wire we use? Thermo wire, or lots of accessories are available. I will discuss it later. If it fails, always you have a plan B. For every step there is a step. If it fails, what is the thing? So, she knows if the staff nurse is experienced enough, if I cannulate, fail after 2 or 3 times, she knows I am going to ask for a pre-cut. So, I need a pre-cut needle. So, that is also there here. Then you need a balloon, and you need a stent, and all those things, and you have a contrast ready and saline ready. Everything is kept ready, so that she need not go in and out. So, everything you should anticipate what you need in this case. And in some cases, I will show you later, if I think this patient may need even a CRE balloon, I tell them beforehand. So, she keep that also ready with the Alliance gun. Okay, as I said, out in the market there are plenty of accessories. You slowly get all these accessories one after other, as you can see here, from one end to the other end. I will start from here. This is the very important piece, that is a bow wire sphincterotomy. Short nose here I am showing you, but long nose and no nose, there are a lot of things available, and a needle knife. These are the two important things I would think it is very important. Of course, you need a biopsy forces, especially periampullary lesion you have, and you have a various types of hydrophilic guide wires, biliary balloon, Fogarty balloon, Dormia 6-wire, 4-wire Dormia basket, and this is spyglass. That is not. These are the two types of the stents. You can see the pigtail stent is a very important, okay, because they avoid unnecessary stent migration. And the self-expanding metal stents, once you start experience, that may be required, especially in a case of a malignant stricture. Coming to the team, as I said, ERCP is a 4-letter word. You have 4 key persons as enumerated here in this one, and they are all standing here. The endoscopist, myself, my anesthetist, the ERCP staffs, maybe 1 or 2, but definitely a radiographer. Okay, and the layout of my OT is also shown here, as you can see here nicely how I am standing. The anesthetist, my staff nurse with all the accessories, he knows exactly what is going to be expected from this one. Let us watch this teamwork, how they work within themselves, trying to perfect the art, because ERCP is actually labor intensive, highly demanding procedure. It comes after a steep learning curve. So, you need to see at least 25 procedures before you start taking, and at least you should keep on persevering for about 150 to 200 cases to have a cannulation rate which is accepted to be around 90%. Okay. So, here once we come what we call end facing, you have to face the ampulla thanks to the shortening of the scope. Then you are able to cannulate selectively the bile and pancreatic duct. I will tell you in the next subsequent thing. Our aim today is to reach up to the ampulla, that is the module 2. Module 3, I will tell you beyond the ampulla how to get into the bile, selective cannulation. If you are not able to do, how to do a pre-cut and a pancreatic cannulation, all those things we will do in the next. And the fourth one, all the complications and what are the challenges and solutions we will discuss, and finally we will have something like a panel discussion. So, that is the way I planned the 5 short course module. As you say, here is how you can see sphincterotomy is getting performed. Once it is done, then the surgeon is pushing what we call a Fogarty balloon, inflating it and dragging it. As he drags it, as you can see nicely, the stone is dropping down into the duodenum. So that's a thing very easily you can do. Especially when there is some suspicious lesions, you can even take a biopsy. For example, if you have a patient with a stricture or the cancer in the pancreas, you have done a biopsy, then you can go and put a stent also. So here is a schematic representation of how you are going to railroad and exchange and leave a Amsterdam type of stent, pancreatic stent, biliary stent, various sizes, various diameters. There are plenty to learn about accessories. We'll do that, but this is in essence what we are trying to achieve. Okay, and this is a glimpse of what a self-expanding metal stent will look like, because they all will go through the channel in the ERCP scope. So once you know how to deploy them, if you, especially when you have a good technician, and it will be a treat to do and treat to see the patient getting well so soon. So let me take you in the next 15 minutes or so with a couple of videos on the key steps to reach up to the ampulla. Okay, to do that, I am having right here a patient whose, as you can see, is a prone. That is the commonest position we normally see. Left lateral, which normally we do for endoscopy, is okay, and the supine, nowadays I am using it increasingly, especially when we do a single stage procedure like lap chole and followed by ERCP. So this is a prone and supine, both you are comfortable, and whichever you can comfortable you can go, carry on, but 90% of them will do in a prone position, because the retention of the scope in the D2 is better and you are better oriented. But the only thing is you need to be very careful about the patient airway, especially when the patient is not intubated. Okay, let me tell you in micro, I told you the last class the importance of the steps broken into micro steps. How are you going to intubate the oropharynx, especially with a side viewing scope? How are we going to navigate blindly down into the esophagus to go into the 40 centimeter and not getting lost in the stomach, reaching up to the pylorus? How are we going to do? And once we see the pylorus and how we are entering the D1, D2, then dock and at the ampulla. So all these things we are going to see in relevance to the duodenoscopy. That's what we are, I am sure. Let us watch one case, then we'll go. Here is what I am saying about the elevator. As you can see, I am testing the elevator going up and down, because if it is not working, there is no point in proceeding. So that is controlled. Big wheel, small wheel, next to this big wheel is the elevator, as you can nicely see demonstrated here. And this scope, what I am having here is fairly a big scope. That is what we call a therapeutic ERCP scope, which is having a diameter about 10.8 and a working diameter, the channel diameter inside where all the accessories go, is 4.2. So very easily you can put a stent up to 10 French stent. So this is what we normally use. If it is a pediatric group or if you want a smaller scope, especially when you have a pyloric stricture, we have another scope which is having a 3.2 millimeter access channel. So depending upon what you need, you choose and then you proceed, and you tell the staffs, and you see an idea where they are all. Say I have 2 staff nurses, especially when we are using a complex procedure, and we have a nicely laid out table as I just showed in the previous one, and see how I am comfortably holding this with a single hand while I am trying to advise the anesthetist to give the injection. And then here all the layout, as we rightly said, the sphincterotomy, balloon. See what you see there, you can see even a glimpse of the Alliance gun, and the patient is there, as you can see, and you can briefly see, I am sure you will be, my person here actually he is actually lifting the patient's shoulder. So the patient, even though he is prone, is brought semi-prone. I am getting inside the esophagus. Now we are in the esophagus. Unlike an end-viewing scope, you can see the view is not very great mainly, but with a big wheel away from you. Okay, big wheel towards you will take it this way, but you want it go other way. So you want to take the big way away from you. So that way you will be able to see the lumen, and as you go along the greater curvature, what we call a long route, you can see the bile and you can see the antrum, and we are nearly going and saying hello to the pylorus. You can see the pylorus for there, and you see what we call a sunset appearance. In other words, the pylorus should come more or less at 6 o'clock. If you treat my monitor like a clock, the clock, you will see the pylorus, the round, the thing, now we are just entered the pylorus. We are going from D1 to D2, the superior duodenal angle. There I just lock the small wheel, just turning it away from me, then push the scope further, beyond the ampulla. You can see the bulge ampulla, junction of the second and third part, and that time I just turn the big wheel completely towards me. So small wheel away so that it turns to the right, big wheel towards, so it goes upwards. So these are the two things. Then you pull the scope, and the scope now hugs the lesser curve and shorten. As you can see, the ampulla is nicely seen, and it is the only longitudinal pole at the top of which you are seeing a small slit like the papilla, the major papilla. Ideally, the major papilla, if you divide this clock into 4 quadrants, it should be in the left upper quadrant, more or less at 10 o'clock position. Why 10 o'clock position, you will be wondering. You will soon understand. All the equipment or accessories coming in the ERCP scope will say hello to you around 3 o'clock. So they are going to come from here, okay. So they are going to come that way. So you need to be very clear the trajectory, how it is going to come. I am just going to see this one from this. So you will see it is coming from more or less like 3 o'clock. So you know the trajectory. You can change the angulation by how much you have a control on the up and down knob of the elevator, and also you can ask the staff nurse to control the bow wire, okay. So there are 2 ways you can control the thing. See, for example, now she is just approximating her hand so that there is a little bowing of the wire. As you can see, the wire is taut, so it is more acute like this, okay. It was like this, so it is now. So both the elevator and bowing helps it to go into what we call towards the direction of the common bile duct, because I told you common bile duct takes a course from here. It goes from the left to this side, it goes towards the 10 o'clock, whereas pancreatic duct will go the opposite direction towards 2 o'clock position. So you have to, so now this angulation, you just mesmerized by this film. This is exactly the location or the direction you want to know. So it is going from your, when you say this side, from my right side, right to left, this side it will go, pancreatic duct will go this way. So you, whether you go look at the monitor and just accordingly you do. So this is what you have to do. As you can see here, the surgeon has nicely cannulated, but don't be in a hurry, because you need to see the fluoroscopy to see whether the cannula or the guide wire is in the right duct, and also you should see a tinge of bile as he is aspirating, ensuring it may be in the bile duct. But still, the proof of the pudding is to see whether the guide wire is along, not across the vertebra, and also you can see the contrast has been injected. You can see a wide cystic duct and the common hepatic duct, and both the right and left hepatic ducts are slightly dilated. How to know the sizes? You see the reference is your 10.2 or 10.8 millimeter size of your scope. Is it smaller than the scope, bigger than the scope? So this common hepatic duct is slightly smaller, so it will be than the scope. So it will be around 9.5 to 10 millimeter diameter. So like that you can have a reference of your scope, because there is some degree of magnification there, okay. So you can see very easily how I am positioning myself and what is the view you are getting inside. I am asking my staff nurse to just pull the wire, tighten it and press the pedal, so that yellow pedal, and get the endocut. Endocut will cut tuck, 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 tuck like that. It is not like zzz like that. It is not like a zipper cut. Zipper cut will cause uncontrolled cut. We want a controlled cut with a hemostasis. The only way is by endocut. RB, there is a effect endocut. I, we have various things available. So we have here VEM, another things, but usually around 30 to 35 watts That's what we go. And very important is a control. How far can you cut? If you ask me here, for example, you can't go beyond that. So if you can see that insert, I'll tell you. So here, for example, this is the fold. You should not go beyond that fold. I have about 2 more millimeter here. I can cut if you want, but otherwise you can just minimize the cut. You can go for what we call a partial sphincterotomy. Then you go for a sphincteroplasty, especially when you are having a fairly large stone like a 10 millimeter or 12 millimeter stone. Nowadays we don't go for a mechanical lithotripsy. Now we go for what we call a balloon sphincteroplasty. So CRE balloon. So that is the what we controlled radial expansion balloon. So this is a balloon what we normally use depending upon the diameter here. So we chose in this patient 10, 12, 15 sized balloon, CRE balloon, and I am going to pass it through with the guide wire, and then the balloon will be 3/4 will be inside the duct, 1/4 will be outside. You will be soon see, and attached to an Allianz gun, and then inflate it under pressure. And on a given atmospheric pressure, I know pretty well this is probably going to be the size. So it's all depends upon, you don't want to overstretch also. It's all depends. Here we know already this patient is having a duct size around 10 to 11. So I am not going to do it beyond 10 or 11 millimeter. So as you can see, the CRE balloon is just in, and I am just asking my staffs, as you can see, watch her hand. She is going to just, it's like a pistol hand. So this inflated with the saline, and gradually a controlled radial expansion, circumferential expansion, stretching it. So this is the best way, and the people were saying it has theoretically an increased risk of post ERCP pancreatitis, but when you do a sphincterotomy, that is going to take all the resistance, so it is going to split that way. So there is no chance of increasing incidence of pancreatitis in my opinion, and you leave it for about a minute so that a degree of hemostasis is also achieved. And she is also telling me from the gauge there what is the atmospheric pressure. So I know it is now around 10 millimeter. So I asked her to deflate it. Once it's deflated, you can see what happens. There is a very adequate opening. So this you can't achieve. Even still you can see a stone drop. You just now saw a stone also dropping. So that's the beauty of this procedure. But even then we normally pass this Fogarty balloon and pass at least 2 or 3 passes and drag it just to ensure there is no other gravel or sludge. And once that done satisfactorily, then you can do what we call an occlusion cholangiogram. What do you mean by occlusion cholangiogram? You just inflate the balloon, drag it down. See, for example, here you can see the balloon is just above the common hepatic duct there, and I am just pulling it down. As you can come, all the sludge and everything, the balloon, inflated balloon came out. That means there is no sludge or a stone remaining. So already stone fell out, but still I wanted to be sure. So I just kept the balloon at the lower end, asked my staff to inject some more contrast and ensure that the contrast fills in nicely. There is no filling defect, and there is easy contrast coming out of the bile duct as soon as I deflate it. So all these things ensures there is no residual stone and there is no definite indication for putting a stent. So we dispensed without a stent because this patient already had a lap chole, so I don't anticipate any problem. So this is a glimpse of what we call an occlusion cholangiogram, the inflated balloon. Now I am deflating the balloon, then going one more time up, then pull it down to ensure for a final time that there is no sludge inside. Okay, so this procedure, if it goes well, it will go so smoothly, and this is more or less like an unedited video. As you can see, this is a final sweep, what we call the balloon sweep. So that is very satisfactory. Then there is no undue bleeding, and this patient has given indomethacin suppositories also by the time she get out of this table, and next day she will be ready for home. So this is the response. When you have a case going so well, obviously the patient's response and also the recovery will be really gratifying for you. Coming to the tips, now you have seen a video. Now I am going to tell in the next 5 minutes the 10 tips you learned or going to learn today. Tip number 1, How to intubate the oropharynx? Because I will tell you the difficult area. First, into the oropharynx, because it is a leap of faith. For that, you ask your assistant who is standing on the opposite side of the table to turn the patient from prone to semi-prone. Hold it there until you go into the pylorus. That is the first thing. The second thing you do is you keep the small wheel locked, so that once the small wheel is locked, you have one thing less to worry about. The third thing is, if you have a big wheel away from you, so the tip will be like, if you see the tip, it will be instead of this, it will be like that. So it will be able to see a little bit better. So these are the three things. I will show you in another video how it is going to be done. So these are the three things. It will definitely make job easy for you to intubate. And because what you are seeing is mostly the side wall, as you can see here, the side wall is only seen, but you go along the long route, okay, you can see along the greater curvature only you are seeing. So how you go? Big wheel down and torque to the right, okay, torque to the right, clockwise torque. Once you do that, you will see the pylorus. How do we know that we reach the pylorus? Sunset position. This is what we see. So sunset position, this is the typical position. That is 3/4 of the pylorus you are seeing, 1/4 is hiding. And then you straighten the scope, you go blindly. That is a leap of faith one more time. But don't immediately try to do all the wheel change. You have to go into the junction of the D1 and D2 to do what we call the change of the wheel of big wheel and small wheel. That is shortening the scope happens at the only in the superior duodenal angle level. That is a big wheel towards you, small wheel away from you, your body should turn to one side, and you shorten the pull the scope, and as you do, you monitor, and you can clearly see what was like this initially along the greater curvature, it becomes along the hugging on the lesser curvature. This is the typical hockey stick appearance. So this is what you need to do, and this is the schematic representation. What was like this, it will become like this. Okay, so this is all because of this wheel, body movement, and the shaft pulled. So this is what you should do. And as I said, you need to remain in D2. Like the case you just now saw, about 5 minutes we finish the whole procedure. Sometimes it will be so frustrating, 40 minutes, 50 minutes it might take. So till the time, how to stay in D2? That is only if you know these 4 D movements. What do you mean by? You should know how to control the big wheel, small wheel, soft, and elevator. So these are all the 4 I call 4D movements. Okay. Coming to the next tip, which I already addressed, we'll see one more time. You try to have your target, that is ampulla. If you divide the screen into 4, the top left, that is left upper quadrant, like 10 o'clock position, because your trajectory is from 3 o'clock towards that. So that is what, keep the ampulla there, and address and understand the ampulla and its parts. Like for example, this also we saw in the last class. You refer, you ampulla is top of the only vertical fold, and it will be nice like a nipple, may have an infundibulum, and even it can have something like a prefuse. You try to see, some ampulla will be so easy to cannulate, some will be hiding in a periampullary diverticulum, so it may be challenging. So all you need to do is to try to go end phase. The one advice I give to the beginner is try go beyond the ampulla at the junction of the D2, D3 before you start shortening the scope. So that's what you should do. See, for example, here you see the various, this is what you should do. Go a little below the ampulla, then you will be able to see the ampulla. You have to look at the ampulla like that. Don't look at, okay, like this. So don't be like this. In other words, your scope should be at least another 2 centimeters down. Otherwise, this is what you will end up seeing, a bulging. So the tip is there, you can't go like this. So you have to go further down like this. This is ideal, this is less than ideal, and this is an unusual situation where you will be able to see 2 separate openings, very rarely. Most of the time you have a common channel. So end facing ampulla is better, don't have a down facing ampulla, that means you have to go further down. Okay, then sometimes you are at the end facing, but ampulla looks far away from you. How to bring it away? Come near. The only way you bring it near is 2 things. One, either you can apply suction or the big wheel. If you take the big wheel towards you, ampulla comes towards you. If you take the big wheel away from you, ampulla recedes away from you. Very simple. So that is one thing. The big wheel come for a rescue to bring the ampulla towards or away. The last step is always, I told you again, importance of the three-dimensional anatomy of the ampulla. That is, the sphincter papillae has sphincter cholecystocus going towards the 10 o'clock, sphincter pancreaticus going towards the 2 o'clock. So those you need to understand, because you have to direct the bow wire and also the pre-cut accordingly. So that is why it is important. Like here, for example, clock levels or positions are critical, like 10 o'clock. What happens if you cut at 12 o'clock, you might ask? Usually the bleeding is undue, unnecessary in that situation. The next is elevator. I am sure I need not tell again and again, the importance of the elevator is essential. Like if the elevator is fully down, you will be able to up into the bile duct. If it is half down, then only it will be like pancreatic duct. And the last thing I wanted to share with you is again reinforcing what we said last class. Understand this course of the bile duct is not just simple gentle curve. It is a S-shaped, like a sigmoid curve of the last 2 or 3 centimeter of the bile duct will be very, very difficult to traverse. Sometimes it leads all your skill. So that's why this little diagram I have given you, just to watch it carefully. There are 3 important movements to easily get in. One, once you go below the end facing, that is you see it, go a little further below, then you pull the scope up, pull up the scope, big wheel towards you, so you go near, and then elevate it down, so it will get in. So these are the 3 important things, okay, and orient, and you try to cannulate around 10 o'clock. So pull the scope up, big wheel towards you. So this is the 2 important things that will straighten the so-called S-shaped curve. So here is, for example, I said this is the ampulla, I wanted to bring it, as you can see it is a little down to my liking. Slowly, if it is little, see, and now it is better. Now it is more or less at the center or in the left upper quadrant. Then the trajectory is okay. Now you see the ideal position is left upper quadrant. Then watch my trajectory. Then use the endocut. Then keep on watching where your guide wire. You can see the guide wire here nicely, faintly you will be able to see the guide wire, and here we have unedited video, so my anesthetist is actually taking the camera, moving from my endo view to the C-arm. That's why, sorry for that. Otherwise you are able to see we have cannulated and we have taken a contrast, and you can see the guide wire inside and also the contrast, dilated duct you can see here, and nicely shortened the things. And this is the way endo cut should be done, like a millimeter at a time, and always see, okay. So you have to so that is the best way, so that there is nothing like a zipper or uncontrolled cut. The controlled cut, a clean cut with the hemostasis. So this is only by endo cut with a yellow pedal. So this, without that, I won't recommend an ERCP can be done safely. Then this is a fairly dilated, as you can see it is as dilated as your scope, so it is around 10.2. So obviously there is a short stricture in the lower end. So we have to identify whether it is a stricture or a sludge there. So we did a balloon sweep to find out. So you will soon find out that we are going to do a sphincteroplasty like last time. So this is another example of a sphincteroplasty being done after further incremental sphincterotomy done. I just want to do it as much as possible. All the bulging infundibular part can be divided. So what you need to do is don't go up to here. That is the first horizontal fold after the bulging amp. So don't go up to there. You stop somewhere here. Another 1 millimeter. That's all. Otherwise, there is every chance of micro perforation, retroperitoneal perforation. That is one of the untoward complication if you are over jealous in your cut. Okay. So this is, see, keep on bowing and keep on testing, and a fully bowed wire should go in and out completely. That is what you want to see, and how I am taking my time and I am trying to direct it. Even though it is more towards 11 o'clock, I am trying to just orient more towards 10 o'clock every time, every chance I am getting. And once you have done that, I am just taking another CRE balloon just to ensure I have a little bit better dilatation. Even if there is a little stricture, it will stretch 3/4 inside, 1/4 outside, and you are able to see completely everything under vision and controlled radial expansion. Wait for about 30 to 60 seconds then deflate, then balloon sweep, like what we do, it becomes like a habit for you. So as we do a CRE balloon, again you can see it has been monitored, and you can see the filling defect. Actually what you see is because of the CRE balloon here. Then wait for some time, then deflate, and once you have deflated and you take the stone out, and if possible or if you suspect there could be some malignancy, whatever may be the things, then you can do what we call a cytology brush you can take, or if you have a spyglass, that also one can advocate. But at your level, this principle is mainly to tell you the importance of the sphincterotomy, endocut, and the importance or the benefit of the sphincteroplasty, balloon sweep, what we have just done. And once we have done, all the exchange has to be done. See, always you have to have a constant communication with your staff nurse. That's what I am trying to do here. And so she is trying to do what we call a railroading, how she is going to. So she needs also a lot of teaching, and we are just putting the stent. As I said, the single pigtail stent has been placed now. And once we have done the procedure, last class itself I said equally important is to have a good documentation. So here is an example of how a documentation for our institution will look like with the hospital details top. But what is important is all the things you have done yourself, patient detail, anesthetic detail, all the appropriate pictures, everything you have to write. So the essence, bare essence are given here. So these are all the things you need to know. And post-operative advice, if the patient has a stent, you have to tell the patient how long after this procedure she needs a stent removal. So that has to be documented there. Also never forget, whatever we do, however careful we are, there is always an element of a problem here, because ERCP is not without complication. There is a 5 to 10% chance of post-ERCP pancreatitis, occasionally bleeding, especially if the coagulation is not properly controlled or corrected. Infection is a risk, especially when you are trying to fill in an obstructed system, or if you are not disinfecting the scope or taking control about the contrast or the fluid you are using. You should be very, very careful. It is like an operation, it is a sterile procedure. Okay, and perforation, if you are careful not to overinflate your balloons, and also you have to be not overzealous with your sphincterotomy, perforation should not be a problem. But still, pancreatitis or all these complications can give rise to a well understood, well known mortality rate of around 1%. That's why it is not without danger, so don't take it lightly. So try to perfect the art, because it is a technically demanding procedure. Every step, as I said now, I have divided step into 3 or 4, but you can divide into 10 or 15 micro steps. Learn them, try to perfect them. I can tell you one clue, and another surgeon or another endoscopist may be able to offer you another tip. So try to accumulate all the tips, try to get a master of everything, because I am sure, like Mount Everest, the learning curve is going to be steep, but the view from there is beautiful. So you plan, perform, perfect the art of ERCP, and I am sure you travel with me for the next 3 more modules. And the next module, I am making the whole thing from what you learn from 1 and 2. I put them along with a few more case capsules as ERCP made simple. So till then, I'll say goodbye. Thank you very much.